If you take a small pill every morning for blood pressure but still feel constantly tired, notice weight gain around your waist, or get out of breath climbing stairs, there's a strong possibility you're on a beta blocker. And current research suggests something many doctors may not fully consider yet. That medication could actually be working against you. I'm Dr. Olivia, and this channel is dedicated to sharing the latest evidence-based information on senior health, explained in a simple way for adults over 60. If you haven't subscribed yet, now is the time, because what we're discussing today could change how you talk to your doctor. Let's begin with beta blockers. You may recognize them by brand names like metoprolol or Lopressor, or by their generic names such as metoprolol and atenolol. These medications have been used for more than 50 years to treat high blood pressure. They are widely prescribed, affordable, and very familiar to doctors. For a long time, they were considered the standard treatment for hypertension. But here's the issue: research has evolved. For many older adults with uncomplicated high blood pressure, beta blockers are no longer the best option and may even cause multiple unwanted effects at the same time. So what do beta blockers actually do? Your heart contains receptors that function like locks, and adrenaline acts as the key. When adrenaline connects, your heart beats faster and stronger. Beta blockers occupy those receptors, preventing adrenaline from attaching. As a result, your heart rate slows and the force of each beat decreases, lowering blood pressure. That approach makes sense, and in certain cases, such as after a heart attack, in heart failure, or with serious rhythm problems, beta blockers are extremely important and can save lives. Their value in those situations is not in question. However, for general high blood pressure in otherwise healthy older adults, the evidence has changed significantly. A major study called the ASCOT trial, Anglo-Scandinavian Cardiac Outcomes Trial, published in The Lancet, followed over 19,000 patients. It compared people taking a beta blocker with a diuretic to those taking a calcium channel blocker with an ACE inhibitor. The study was stopped early because the results were so clear. Patients on beta blockers experienced more strokes, more heart attacks, and more cases of newly diagnosed diabetes. Meanwhile, the group taking calcium channel blockers had 23% fewer major cardiovascular events, a substantial difference. Because of this and similar research, the UK's National Institute for Health and Care Excellence removed beta blockers as a first-choice treatment for hypertension. They are no longer recommended as the primary option in British guidelines. Despite this, many people, especially in the United States, are still taking beta blockers as their main blood pressure medication. Often, this is simply because the prescription was started years ago and never reevaluated. Now let's look at how these medications may negatively affect people over 60. One major concern is fatigue and reduced exercise capacity. By blocking adrenaline receptors, beta blockers limit how much your heart rate can increase during activity. For younger, less active individuals, this might not be noticeable. But for older adults who want to stay active, walking, swimming, or playing with grandchildren, it can make a big difference. You may find yourself getting tired more quickly, feeling short of breath sooner, or experiencing heavy legs during physical activity. Since exercise is one of the most effective natural ways to lower blood pressure, struggling to stay active creates a difficult cycle. The medication makes exercise harder, and less exercise means blood pressure may remain high. For example, a 71-year-old man named Harold reported severe fatigue that caused him to stop his daily walks. He had been taking atenolol for 3 years. During that time, he gained 14 pounds. His blood sugar moved into the prediabetic range, and his energy levels felt consistently low, like he was operating at half capacity all day. His previous doctor had attributed these symptoms simply to aging. However, when we reviewed his medication in light of current research, the situation became much clearer. The second major concern is metabolic impact, and this is strongly supported by evidence. Beta blockers are known to increase insulin resistance, raise triglyceride levels, and reduce HDL, the so-called good cholesterol. A large meta-analysis published in the Journal of the American College of Cardiology reported that individuals taking beta blockers had a 22% greater risk of developing type 2 diabetes compared to those using other blood pressure medications. For older adults who are already managing blood sugar levels or are in a prediabetic state, this represents a significant additional risk, especially when the medication is not more effective than available alternatives. One of the most surprising findings when analyzing this data is that beta blockers often do lower blood pressure readings. On the surface, the numbers may look perfectly fine. However, the concern lies beneath that surface. Metabolic changes, cardiovascular outcomes, and a gradual decline in overall quality of life. It's entirely possible to have a reading like 128/78 while still experiencing underlying harm if the medication is negatively affecting your metabolic health at the same time. The third issue is fall risk, which is often underestimated in older adults. Beta blockers can lead to orthostatic hypotension, a sudden drop in blood pressure when standing up from a sitting or lying position. That brief feeling of dizziness when getting up from a chair may seem minor, but for someone aged 73, it can have serious consequences. It can easily lead to a fall. In seniors over 70, hip fractures carry a one-year mortality rate close to 30%. A fall caused by medication is not a minor event. Before discussing better supported treatment options, it is essential to make one point very clear, as it could be life-saving. Never stop taking a beta blocker without medical supervision. Suddenly discontinuing it can cause a rebound effect, where heart rate and blood pressure increase rapidly. In some cases, this can trigger a heart attack or a serious heart rhythm problem. Any change in this type of medication must be carefully managed by a doctor and gradually reduced over several weeks. The purpose of this information is to help you have an informed discussion with your doctor, not to make independent changes to your medication. So, what alternatives does the research support for older adults with uncomplicated high blood pressure? Two categories of medications stand out. The first is calcium channel blockers. Amlodipine is one of the most commonly prescribed drugs in this group. The ASCOT study showed clear advantages of this class over beta blockers. They do not carry the same metabolic side effects and do not restrict exercise capacity in the same way. Additionally, a large study published in the British Medical Journal found that amlodipine was linked to a significantly lower risk of stroke compared to atenolol in elderly patients with hypertension. The second important group includes ACE inhibitors and ARBs, angiotensin receptor blockers. Medications such as lisinopril, ramipril, losartan, and olmesartan have consistently demonstrated benefits in older adults. These include kidney protection, improved outcomes for patients with diabetes, and a lower risk of falls. ACE inhibitors can cause a persistent dry cough in about 10 to 15% of patients. If that occurs, switching to an ARB is usually a better option, as it works in a similar way without causing the cough. Dorothy was 74 when her cardiologist reevaluated her long-term use of a beta blocker and gradually transitioned her over 8 weeks to a combination of amlodipine and losartan. Within 3 months, her fasting blood sugar returned to normal. She lost 7 pounds without making any deliberate dietary changes, and she said she finally felt like herself again after years. Her blood pressure readings also became more stable, not less. So, here is what you should do with this information. First, review your current medications and determine whether you are taking a beta blocker specifically for blood pressure. Not for a diagnosed heart rhythm condition, not for post-heart attack care, and not for heart failure, but only for hypertension. Common names include metoprolol, atenolol, bisoprolol, propranolol, and carvedilol. Second, prepare 3 specific questions before your next doctor's visit. Ask your doctor, was my beta blocker prescribed only for hypertension, and does that still align with current evidence-based guidelines? Ask, have my fasting insulin and triglyceride levels been checked recently? And ask, based on my overall health, would I be a suitable candidate to switch to a calcium channel blocker or an ARB? Third, request a complete medication review. If you have been taking the same blood pressure medication for more than 2 to 3 years without reassessment, it is reasonable to ask for one. Many older adults are still on medications that were standard practice years ago but have since been reevaluated. Fourth, if a change in medication is suggested, make sure to confirm the tapering plan with your doctor. A careful physician will reduce beta blockers gradually, usually over 4 to 8 weeks, while monitoring your response. Fifth, start tracking your symptoms now. Keep a simple daily record of your morning blood pressure, your energy level on a scale from 1 to 10, and your fasting blood sugar if you are monitoring it. Having 3 to 4 weeks of personal data gives your doctor useful information and makes the discussion more effective. Before we finish, one important clarification. There are many patients for whom beta blockers are still the right and necessary treatment. If you have coronary artery disease, a history of heart attack, diagnosed heart failure, or certain heart rhythm disorders such as atrial fibrillation, the situation is different. In those conditions, the benefits of beta blockers are well established. The concern discussed here applies specifically to older adults whose only diagnosis is high blood pressure without other heart-related conditions. If that describes you, this is a conversation worth having with your doctor. If your blood pressure medication is leaving you feeling exhausted, if your weight is gradually increasing, if your blood sugar is trending upward, and your prescription has not been reviewed in years, you now have the research, the language, and the right questions to approach your next appointment differently. You deserve a treatment plan based on current evidence, not outdated practices. If you plan to discuss this with your doctor, comment reviewing mine. Also, share your current blood pressure medication below. I read every response, and your question could be featured in a future discussion. If someone you care about is struggling to manage their blood pressure, share this information with them today.